In this video, we'll present the endovascular management of a patient who has a bilateral direct carotid cavernous fistula. The fistula was treated with a combination of coils and onyx. The patient is a 55-year-old female who presents to the ophthalmologist with a subacute onset of bilateral retroocular pain, double vision, periorbital edema, and myoproptosis. She did not have any past medical history of significance, no trauma on examination. She had bitemporal fluid. CT and MRI were consistent with the cavernous sinus fistula with prominent vessels and enhancing of the sinuses. Diagnostic angiogram confirmed a direct carotid fistula bilaterally. The patient was taken for a diagnostic angiography and endovascular treatment under conscious sedation. We obtain access into the right femoral vein and into the left femoral artery. Left internal carotid artery demonstrates the fistula, high flow fistula, as you can observe. Significant components of the fistula were observed. Then a 6 French catheter was navigated into the left sinus, sigmoid sinus, and using a microcatheter we get access into the inferior petrosal sinus until we reached the cavernous sinus, but we went also to go to contralateral since the fistula was bilaterally. So we crossed to the other side of the sinus, and once we reach the right side, we start packing with coils. Multiple coils were used and different sizes to start coiling from the right to the left. We tried to maintain the position of the microcatheter within the sinus as much as we could. Once we have packed both sinuses with coils, we do another venography to assess the vasculature and the anatomy of the venous structure that have been embolized. We then inject onyx to really fill up the spaces between the coils and the inferior petrosal sinus. Coils is injected. We're trying to send onyx contralaterally into the other cavernous sinus. This is the final result, and so far we have no more access from the venous side. So in order to complete the treatment of the fistula, we did a balloon test occlusion, and the patient did tolerate occlusion of the left internal carotid artery. 20 minutes of a balloon test occlusion inducing hypotension. So the rest was a transarterial embolization or sacrifice of the left internal carotid artery with large coils. Again, we did this procedure under conscious sedation, so we could assess the patient neurologically throughout the balloon test occlusion. So finally, we inject some coils followed by onyx to really complete occlusion of the carotid artery. Left internal carotid artery angiography demonstrates complete occlusion of the artery. The patient again remained neurologically intact. Contralateral right internal carotid artery angiography demonstrate very good collateralization into the left hemisphere, and the patient was treated successfully and remained neurologically intact thereafter. Thank you.